Reminders to all our attendees of the 12th Biennial Symposium. Before we get started, if you have any questions during any of the presentations, please feel free to type in your questions in the chat box and our speakers will answer them in the chat box. Or you can personally send us a message at pflhrd@gmail.com. A friendly reminder to all our participants that microphones are muted by default during the entire presentation. And please kindly answer the evaluation form after the last speaker of the session, and link will be seen in the chat box. CPD units will be provided, and your e-certificate will be issued through your email within 2 weeks. Thank you for being part of the success of this biennial symposium. Moving on, our second speaker, he had his fellowship training in pediatric pulmonology and critical care medicine at the Philippine Heart Center. He is a fellow of Philippine Pediatric Society, Philippine Academy of Pediatric Pulmonologists, and a fellow of the Philippine Society for Critical Care Medicine. He was a former training officer of pediatric pulmonology at the Philippine Heart Center and currently a medical specialist in the Philippine Orthopedic Center. Presently, a board member of the Philippine Foundation for Lung Health Research and Development. I'm honored to welcome our second speaker, Dr. Dr Astrologio, to talk on the oxygen therapy. Flash in front of you are the list of his objectives.
Magandang gabi po sa inyong lahat. I am Dr. Gary Astrologio and I am tasked to talk about the basics of oxygen therapy. Well, I'll go straight to the lecture. We are given a limited time to discuss about this topic. As I go along, I'll be giving some introduction about the oxygen therapy, the indication why we use oxygen, and I'll be concentrating more on the different delivery system that we encounter in the clinical setting. The last part of my lecture would be dealing with the complications of this oxygen therapy. Well, the main goal of your oxygen therapy is to maintain adequate tissue oxygenation while minimizing cardiopulmonary work. Well, oxygen therapy is commonly seen as a supportive treatment for patients with acute respiratory failure, for those with chronic lung diseases, and with hypoxemia. So, what you aim to do is to maintain a normal hemoglobin saturation so as to facilitate normal oxygen delivery to the peripheral tissue. Well, the main objective of your oxygen therapy is to correct either the documented or suspected hypoxemia in your patients, and in doing so, decrease the symptoms associated with these chronic hypoxemic conditions. Also, the objective of this therapy is to decrease the workload hypoxemia imposes on the cardiopulmonary system. So when is oxygen therapy indicated? When there is this documented hypoxemia. How do we say it's documented hypoxemia? If you look into your arterial PO2, there's this less than 60 millimeter mercury, or your O2 saturation is less than 90% on room air. Also, your arterial PO2 and your O2 saturation is below the desirable range for a specific clinical condition. Of course, in cardiac patients, they have lower O2 saturation, lower O2 threshold, So somehow you need to consider the clinical situation or the disease that is present in your patient. Now, oxygen therapy is also indicated, especially in acute care situations in which hypoxemia is suspected, no, in mga asthma cases ninyo, pneumonia, no. Also, it is indicated in severe trauma, in cases of myocardial infarction, and also at a short-term therapy, like in your post-anesthesia recovery. Let us then go into the different classifications of your O2 delivery system. They are classified by design and by performances. By design, this auto delivery system is classified as low flow system, high flow system, the reservoir system, and enclosures. I would then discuss all this later on as I go along. Now, when it comes to performances, no, this is based on the predictability and how this delivery system consistent with the fraction of inspired air supplied by it. No, so it's either fixed or it's either variable performance. When we talk about the low flow system of oxygen therapy, the gas flow in it is insufficient to meet the patient's peak inspiratory and the minute ventilatory requirement. Now, the inspired fraction of oxygen that goes in varies with the patient's ventilatory pattern or effort, and provided oxygen is always diluted with air. So this type of flow system has this low delivery and a variable inspired fraction of oxygen. So it's considered to be a variable performance device. I'll give you an example later on. In contrast, the high flow system, the gas flow in it is sufficient to meet the patient's peak inspiratory and minute ventilatory requirement. Now, the FiO2 in this oxygen high flow system is independent of the patient's ventilatory pattern. It delivers low to moderate and fixed FiO2. So this is considered to be fixed performance device, no, as compared to your low flow system, which is a variable type of device. Let us then go to the reservoir system. When we talk about this type of system, it stores a reserve volume of O2 that equals or exceeds the patient's tidal volume in order to provide a fixed moderate to high FiO2. So this is considered as a variable performance device. Again, I would be giving you examples later on. So just for a quick recall, the low flow system and your reservoir system are considered to be a variable performance device, while your high flow system are considered to be fixed performance device in giving oxygen therapy. As I have said earlier, I'll be discussing this different oxygen delivery system. Now, as you could see here, these are the different delivery system under the low flow, the high flow, and your reservoir system. For the low flow, we have the nasal cannula that you often see, no? Your nasal catheter, your transtracheal catheter. For the reservoir system, we are talking of this reservoir cannula. I'll show it to you later. The simple face mask, which is very common as well. The partial rebreathing mask, the non-rebreathing mask, as well as the tracheostomy mask. No, we have to understand this different mask in order for you to give your oxygen sufficiently. No, especially when you are giving high oxygen supplementation. Now, another form which is in the oxygen delivery system is the high flow. No, this is actually a fixed performance device. Examples of this are the Venturi mask, no, the aerosol mask, and the DPs with nebulizers. First, we would describe the low flow system, and the first it would be the nasal cannula. Well, all are familiar with this type of delivery system. It's a plastic disposable device which has a prong around 1 centimeter long connected to an oxygen tubing, and this is somehow inserted through the nares of your patient. Now, you need to take into consideration the gas flow that you would be delivering. For adult, the highest is around 8 liters per minute, and it could go as low as less than 1 liter per minute. Now, for children, we often give the gas flow of around 2 liters or less. No, oftentimes there would be discomfort if you give a higher gas flow. No, and then they would describe sometimes that they feel like nalulunod. no, with the oxygen flow that you're giving. So this type of nasal cannula is able to give oxygenation at around 24 to 40%. Thus, it's really a low flow system. Well, for these different systems, no, we need to look into the advantages and disadvantages. For nasal cannula, we know it's easy to fix, it's hands-free, and there's not much of interference needed when you need to do further airway care. It's low cost. In fact, it's the cheapest of all the low flow system, and it's quite compliant. For the disadvantages, well, it's unstable, easily dislodged, especially in children. You would know upon head turn, natatanggal yan agad-agad, no? And when you're using high flow, it's quite uncomfortable, no? And it causes nasal trauma because of the prong, no, poking in doon sa external nares, mucosal irritation. Sometimes it makes the mucosa dry, no? And so it is easily irritated. And then the FiO2 that you're giving can be inaccurate and inconsistent. That's why they consider this as a variable flow system. How do we estimate the fraction of inspired oxygen, or what we call the FiO2, when you deliver the treatment through nasal cannula? In a patient of normal ventilatory pattern, the room air is around 21% or 0.21. So as you add 1 liter per minute, no, through nasal cannula, it increases the FiO2 approximately 4%. So at room air, 21% or 0.21. If you add in 1 liter per minute, you increase the inspired oxygen fraction up to 0.24, and at 4 liters at 0.36, and at 6 liters as high as 0.44%. That's how you estimate the inspired oxygen fraction upon delivery with your nasal cannula. Another low flow system is the nasal catheter. It's just like putting in a cannula, but this one is much deeper. So you put in this tube that reaches from your nose down to the nasopharynx, and this is through the nasal catheter. Well, unlike nasal cannula, nasal catheter are more stable. No, it's still disposable and considered one of the cheapest among the low flow system oxygen delivery. Now, with nasal catheter, the problem is sometimes it's difficult to insert, especially where they're in challenging conditions like the presence of nasal polyp, may mga deviated septum that may block the insertion. So you need someone that is skilled in doing insertions of your nasal catheter. You might witness some back pressures, no, or flow when you're giving high oxygen supply, and you may provoke gagging, sometimes air swallowing and aspiration upon using this nasal catheters. And of course, just like other system, you need to change it regularly. The last of the low flow system that I'll be discussing is the transtracheal catheter. It's a small plastic catheter that is surgically placed in the neck of your patient that sits at your windpipe or your trachea. Now, the oxygen is delivered through the catheter directly into your windpipe, and the procedure should not be confused with tracheostomy. It's of different apparatus, and they are entirely different. With the transtracheal catheter, it makes use of a thin polytetrafluoroethylene catheter, or the Teflon, which is inserted surgically through a guide wire between the second and the third tracheal ring. Usually, you deliver a gas flow of around less than 1 to 4 liters, no, and you'll be able to reach around 22 to 35 or 40% of inspired oxygen. When you insert transtracheal catheter, somehow you increase the anatomic reservoir. Sometimes transtracheal catheter is considered because of the lower O2 supplementation, therefore lower on cost. It eliminates nasal and skin irritation, just like we see in nasal cannula and the use of nasal catheter. It has a better compliance because it allows an increased mobility in the part of the patient. And studies have shown that the use of transtracheal catheter increase exercise tolerance. Now, when it comes to disadvantage, because it is surgically inserted, therefore it's more of a high cost procedure, then it might entail as well complications like infection, no? Mucus plugging is possible, and you might lose track where the catheter is situated, especially if your patient is so mobile, it may become dislodged. So you need to consider this advantages and disadvantages upon using this type of flow system. Let's go to another reservoir system, which is very common, and it's the mask reservoir system. There are about three types: the simple phase mask, the partial rebreathing mask, the non-rebreathing mask. No, so masks are not all the same. No, you have to understand which mask is appropriate for the condition of your patient. For a regular face mask, no, this serves as a reservoir for at least 100 to 200 ml. It's a variable performance device, and your FiO2 varies. It depends on the amount of your O2 delivered, the mask volume. So it's quite important for you to give a proper size of a face mask, the extent of air leakage because of the inhalation and exhalation port, no, the patient's breathing pattern. With this regular face mask, you would be able to deliver an FiO2 at around 40 to 60% effectively. Now, the gas flow range is around 5 to 8 liters per minute. So the minimum flow, please take this into consideration, is 5 liters per minute in order for your patient to prevent CO2 rebreathing. So this is a regular face mask. Regular face mask can be used when you intend to give a moderate but variable FiO2. This is good for patients with blocked nasal passages and those mouth breather. It is then easy to apply. We all know about this. Although it is quite uncomfortable, no, it interferes with further airway care kasi naka-cover yung nose and the part of your mouth, and proper feeding is really required in order for you to efficiently deliver oxygen. There's this risk of aspiration in unconscious patient, and CO2 rebreathing is possible. So you need again to consider giving the least at around 5 liters per minute in order to prevent this. Now, the O2 flow rate at around 5 to 6 liter per minute will give an inspired fraction of oxygen at around 40%, 6 to 7 around 50%, and 7 to 8, which is the maximum for a face mask, around 60%. Now let us talk about these two different masks, this partial rebreathing mask and the non-rebreathing mask. You need to know the importance of these inhalation ports or valves, and this presence of reservoir bag in order for you to identify which is more appropriate for use to your patients. With the use of the partial rebreathing mask, during expiration, the oxygen plus the first third of the exhaled gas enters the bag, and the last two-thirds of the exhalation goes throughout the ports, no, as you would see here in the diagram. These are the exhalation ports, no, and during inspiration, the first exhaled gas and the O2 are inhaled. So the partial rebreathing mask is able to give you an inspired fraction of oxygen at around 60 to as high as 80%, and the fresh gas flow is around 8 liters per minute. So the gas flow that you might be providing in order to have an 80% FiO2 would be as high as 8 liters per minute, and the bag should remain inflated for you to ensure that the highest FiO2 is given, and to prevent CO2 rebreathing. For the non-rebreathing mask, it has three unidirectional valves. The left and the right valve situated at the expiratory port that prevents air entrainment, and then the inspiratory valve preventing the exhaled gas flow into the reservoir bag. Now, with non-rebreathing mask, the inspired oxygen that you could deliver would be around 80 to 90%, and the gas flow that you need to provide is around 10 to 15 liters per minute. Now, to deliver approximately near 100% O2, the bag again should remain inflated, and you need to consider air leakage as well as the patient's breathing pattern in order for you to effectively utilize this non-rebreathing mask. Let us now discuss high flow system, the air entrainment devices, which mechanism is based on Bernoulli principle, wherein a rapid velocity of gas exiting to a small orifice would create a subatmospheric lateral pressure, and this would result in the entrainment of atmospheric air now being combined into the mainstream. So the amount of air entrained would differ directly with the size of the port of the device and the velocity of the O2 at jet. Now, they dilute oxygen source with the air, therefore you would be delivering FiO2 of less than 100%. And the more air entry they entrain, the higher is the total output flow, but there's this lower delivered fraction of inspired oxygen. One of the high flow system that we use is the Venturi or the Venti mask. The mask consists of a jet orifice around which is an air entrainment port as seen here in the diagram. Now the inspired fraction of oxygen is regulated by the size of the jet orifice and the air entrainment port. So this is used to deliver a low to moderate inspired FiO2 around 0.24 to 60%. And this type of mask is considered the high flow fixed performance device. These are the two examples of your Venturi mask. The one on the left with different colors corresponds to a different FiO2. The other one is a full assembly with a dial type, no, and you just need to turn the Venturi device in order to correspond to a specific FiO2 that you are requiring. This is another form of a high flow system, which is the blending system, wherein there's this separate source for your pressured air and oxygen. Now, the gases are mixed either manually or with the use of a blender, and you could deliver inspired fraction of oxygen as high as 100% and as low as 24%. It allows precise control over both the FiO2 and the total flow output. So this high flow system is considered a true fixed performance device. This is commonly seen ngayon, used for COVID patients. Ito yung sinatawag natin na high flow. So ito po yun. So the last type is the enclosures, which is consist of oxygen tent, the oxygen hood, and the incubator, which are used for pediatric mga neonate patients. Well, next is the oxygen tent. You might have seen one. It consists of a canopy placed over the head, and sometimes it covers the whole body of a pediatric patient. It could deliver at least 40 to 50% FiO2 with a flow of 12 to 15 liters per minute. So it's kind of expensive kasi continuous flow of 12 to 15 liters per minute. It's of a variable performance device, and the good thing with the tent kasi it provides concurrent aerosol therapy. May mga contraption siya on the side. Again, disadvantage, expensive, no, it's difficult to clean. There could be leaks, no, kasi ang daming contraptions, ang daming connections, and it would limit patient's mobility. Nakakulong lang siya doon. Well, with oxygen hood, it's only the head of the infant that is covered. This is a fixed performance device wherein you could deliver FiO2 as low as 21 to 100%, but then the minimum flow that you could give is 7 liters per minute to prevent CO2 accumulation. Well, regularly, it's just an O2 tube connected to the source and then to this O2 hood. But then in a highly technical setting, the O2 is delivered either through a heated entrainment nebulizer or a blending system. Well, incubators, are considered to be enclosures, oxygen enclosures. It's made up of special material, and it provides a temperature-controlled environment for the infant. It could deliver at least 40 to 50% FiO2 with the flow of 18 to 15 liters per minute. And these incubator enclosures are considered to be a variable performance device. And for the last part of our discussion, we have the complications of oxygen therapy. I'll go fast with this. We are running out of time. One is oxygen toxicity, the depression of ventilation, retinopathy of prematurity, the absorption atelectasis, and fire hazard. For the oxygen toxicity, the primarily affected are the lungs and the central nervous system. There are two factors, your level of arterial PO2 and the amount of exposure time. With CNS oxygen toxicity, you often observe the tremors, the twitching, and in severe conditions, convulsion. With the mechanism of pulmonary oxygen toxicity, with the high O2 tension that's being given for a prolonged period of time, there's this intracellular degeneration of free radicals that reacts to your cellular DNA, your proteins, and your lipids, no forming cytotoxicity. It damages the capillary endothelium. So what happens is that there's an interstitial edema, the thickened alveolar capillary membrane, and the ensequelae of pulmonary fibrosis and hypertension. So what about the depression of ventilation? You often see this in COPD patients wherein they have this chronic hypercapnia. The mechanism behind is that the heightened arterial PO2 suppresses the peripheral chemoreceptors that depresses the ventilatory drive. So what happens? There's a further increase of your PaCO2. Another mechanism is the ventilation perfusion mismatch, increasing the dead space that causes the increased PaCO2, and that's how your depression of ventilation happens. When it comes to the retinopathy of prematurity, you often see this in premature or low birth weight infant who receive supplemental O2. There's this increased arterial PO2 that is causing retinal vasoconstriction. Therefore, there's this necrosis of blood vessels and new vessels are being formed. And these newly formed vessels are quite friable that causes microhemorrhages leading to retinal detachment and blindness. Now, the strategy here is to minimize the risk of ROP by just putting your PaO2 below the level of 80 millimeter mercury. The second to the last complication is absorption atelectasis, which happens in the underventilated alveoli, which is the alveoli A depicted in the picture. So if you give high oxygen supplement of 100%, the tendency of the oxygen is to wash out all the nitrogen. And mind you, this nitrogen volume is needed to maintain the critical alveolar volume to keep it open. So if you wash out all the nitrogen, the tendency is for the alveoli to collapse, causing atelectasis. Well, oxygen is a fire hazard, no? High FiO2 increases the risk of fire. So in order to prevent this, you need to give the lowest effective FiO2, no? Avoid the use of outdated equipment, yung mga sirang gas regulator, fire prevention protocol, especially in a hospital setting, in an ICU setting, should be observed. And so this is the last slide, and I think I had delivered all the essential information despite a very restricted time limit. But I'd like to remind you all that oxygen is a form of a drug. When appropriately used, it is extremely beneficial. When misused or abused, it's potentially harmful. Maraming salamat po. Thank you for listening.
Thank you so much, Dr. Astrologio, for the concise yet very informative lecture on oxygen therapy. Now, as a way of our appreciation, the Philippine Foundation for Lung Health Research and Development, in cooperation with the Philippine Heart Center Division of Pulmonary and Critical Care Medicine, we would like to show our gratitude and present our certificate of appreciation to Dr. Gary Astrologio as a speaker for imparting his knowledge on the oxygen therapy during the 12th Biennial Symposium today, September 15, 2021, signed by our President, Dr. Cesar Ligo, Dr. Eileen Guzman Banzon, the head of the Division of Pulmonary and Critical Care, and the members of the organizing committee. Thank you, sir. With that, we would like to thank our speakers for imparting their knowledge, and to our audience, we appreciate your time and for being with us today. And we would like to invite you to the Boehringer Ingelheim Dinner Symposium after the last session.